Good afternoon, everybody. It is November 20th at 1 p.m. Eastern Time, and welcome to the HCMA's Facebook page. Today, we are really excited to welcome a new member of the HCMA Recognized Center of Excellence program, which will be Advocate Aurora St. Luke's. And today, we are joined by the program director, Dr. Jamil Tajik. Welcome, Dr. Tajik.
So nice to be here with you, Lisa. So nice.
So nice to have you here. I'm going to give a little housekeeping tips to everybody who's joining us today. And during our talk, we're going to be going over some questions and answers. And as everybody kind of populates in here, I may have to go back and remind them of the rules of engagement. But as we go forward, we're going to be talking to Dr. Tajik about the new program. And if time permits, at the end of the broadcast, we may open up to questions and answers. Please remember to keep your questions specific, or I'm sorry, not specific to your individual case, but more broad in the presence of hypertrophic cardiomyopathy knowledge, understanding, because we can't give personal consults over social media. So I see we have a number of people joining us right now. So welcome, everybody. And again, welcome, Dr. Tajik. So I have to give a little history here because I've known your name a really long time. As we founded the HCMA in 1995, yours was one of the first names that I saw appear on a lot of journal articles that I was reading to help myself become educated with HCM. So tell us a little bit about how and when you got involved in hypertrophic cardiomyopathy.
It's a long story.
I know.
I got interested in a condition. In those days, it was referred to as IHSS, idiopathic hypertrophic cardiomyopathy, starting in 1970. When I started my fellowship in cardiology at Mayo Clinic, patients with this condition were being referred to Mayo Clinic because it was felt to be a unique, a very rare or rarely seen, very complex. Etiology was unknown. Obstruction was one of the main reasons they were being sent for surgical intervention by the expert cardiac surgeons of Mayo Clinic. And so we became very interested and intrigued by this condition. And I must say, in the last almost close to 50 years now, I am still very intrigued by it. And it is so unique. Each patient is different. Each patient needs a very personalized care. And that's what it's all about.
So you mentioned that you used to be at the Mayo Clinic. How long did you spend at the Mayo Clinic and what positions did you hold there?
I spent my whole career, I keep referring to it as first half of my whole career at Mayo Clinic of spanning 41 years.
41 years.
While there, I was instrumental in starting the first hypertrophic cardiomyopathy specialized clinic at Mayo Clinic. And at that time, Dr. Nishimura was the director designated for the center, and Steve Arman, who's the current director, was still the director up till recently, was the co-director at that time.
So you left Mayo Clinic a number of years ago, and you moved one state over to Wisconsin. So how long have you been at Advocate Aurora St. Luke's?
So first move was from Mayo Clinic, Rochester, Minnesota, to Mayo Clinic, Arizona.
Right.
Where I was there for about 4.5 to 5 years and opened the hypertrophic cardiomyopathy clinic at that place. There was Dr. Chris Appleton and Steve Lester. They are already doing some of those cases, and we make a more formalized approach to the hypertrophic disease. And then I was missing Midwestern culture and all that cold. So
snow, you missed the snow.
And this time to by the waters and somewhat warmer than Minnesota is Milwaukee. And I've been here now close to 9, almost getting to be 10 years.
Okay. And since that time, I've been kind of trying to get you on the team, and we finally formalized the relationship, although we've been referring patients to you for some time because you have such a vast depth of knowledge. I mean, you were there for the beginning of a lot of the things that we take for granted today, like echocardiography and when to put in a defibrillator and how to identify which patients are appropriate for which therapy. You've been so critical to patient care. I'm not so sure that everybody else in our community of patients knows that, and I want to make sure that they do. So you've moved over to a new hospital system. You've created a wonderful structure there. Can you tell us a little bit about the team that you've put together at Advocate Aurora?
So part of my move was contingent upon having a expert multidisciplinary team here. And because that's what it takes to take good care of patients, ideal, perfect care of each individual patient with hypertrophic cardiomyopathy. And having been assured of that kind of expertise being present here, and I can, validate that since my experience has been here, it's been now a very, very fruitful relationship with the multidisciplinary team, all involved in the care of such patients and supported by a tremendous, fantastically trained staff. And some of the names that I will just mention to you include starting from the two excellent, par excellence nurse practitioners, both Michelle Bush and Heather Sanders are the nurse practitioners dedicated, devoted to the Hypertrophic Cardiomyopathy Center. We are supported by the receptionist staff, Anna, by the individuals making the appointments, Cindy and Tammy there, and of course my administrative secretary, Jackie Acosta, plays a very critical role in all of this operations. Then, of course, we have surgeons, Dr. Paul Werner being the premier surgeon for myectomy cases. Both the subaortic and midventricular type of myectomies are very successfully been done here. And alcoceptor ablation, Dr. Bajwa, Dr. Alakaban, and now Dr. Fawad Jan, who's also the co-director of this team. We are supported by fantastic imaging expertise, Dr. Ranuka Jain, Dr. Muthukumar, Dr. Galaska, providing both the echo advanced imaging, TE, as well as CT and MRI. Dr. Port is our senior CT specialist who oversees all of those imaging expertises. And then we move on to the very important team of electrophysiologists. Dr. Sra, who's also now the chairman of the cardiovascular service line at Advocate Aurora, is the main person as in charge of the EP program, and Dr. Anwar Dalla and Dr. Asha Jahangir are very important team members there. We have also the geneticists, the genetic support individuals that help us in selected cases. And move on to the heart failure team and transplant team. When advanced heart failure presentation is present, these individuals, Dr. Suleimanji, Dr. Asad Ghafoor, and surgeons like Drs. Downey, Crouch, are helpful in providing the advanced therapies for these patients. So that's just a nutshell of some key individuals that are present. I don't think I forgot many, but I may have. Pediatric cardiologist, yes, I did forget that. And his group also sees the younger individuals that on family screening turn out to have either gene positive status or have the disease. They are involved in the care with us.
That is a robust team that you have established there. And I've had the opportunity to meet with just about all of them at this point. In fact, I just ran into one of them at the AHA conference last weekend.
Yes.
So that was nice. It was the first person I saw when I got on the floor there. So we have the ability within your center to see adults and pediatrics. So parents can come in from a distance and bring their kids for a screening and organize a day or two with you guys and have everybody evaluated within a day or two. Does that work out well?
So it basically, exactly right. Within a day, most of the testing is completed, since they come to us with known or suspected diagnosis, some of the testing has been already done, so we can make a very clear list. The nurse practitioners review the charts and then decide on what are the most appropriate testing to be done, like MRI, like stress testing is all arranged. But as part of our evaluation begins in our suite, outpatient suite, with a comprehensive 2D Doppler, 3D imaging with echocardiography. That to me is the cornerstone that establishes the entire workup and assessment. Expert sonographers, they are trained in this area and they provide that expertise. Each study is then monitored by myself before the patient leaves the echo room. So if additional pieces of information are needed, we obtain that. And after that, patient goes into the consultation room where we provide them with the comprehensive approach with nurse practitioner and myself, and from time to time with the genetic counselor.
That sounds quite comprehensive. I recall when I visited your program a few months ago, walking into your conference room and seeing a whiteboard filled with all kinds of different genetic information on there. And so it appeared to me that there was some research interest and intrigue in the genetic etiology of HCM. Are you doing any research work in this particular area?
So genotyping is a part and parcel of the evaluation of these individuals, because number of times a phenotype that appears like hypertrophic cardiomyopathy may be a copycat condition. And that needs to be deciphered both by imaging, but more specifically by genotyping. So that is routinely performed. There's rarely an individual who refuses to get the genotype done, but almost all patients agree to it for very appropriate reasons. All is explained. And the beauty of my practice at this institution is the convenience of getting the complete family screening done. Right. That was one of the toughest things to achieve at Mayo, because that's far away. All families can't travel there, so that was left to be done at other places and wasn't as robust as is possible now in this particular practice.
Exactly. I will give a chime in here that the HCMA has established a relationship with Invitae now that we will provide full genetic testing for free when you use the right form. So anybody who's watching who may not be in the area of Dr. Tajik and Aurora, Advocate Aurora St. Luke's, they can access that information at 4hcm.org and get the proper order form. And everybody can have access now. There's no cost limitations to it at this point. So take advantage of it while it exists, and we'll be in good shape there. What other research interests do you have in hypertrophic cardiomyopathy?
Well, as you know, imaging is at the core of all this. So advanced imaging is now really being done. And we are just right now collating our whole data on advanced imaging and hypertrophic cardiomyopathy, including the cardiac MRI piece. So correlating excellent phenotyping by echo, as well as excellent set analysis by the MRI, and finding where useful clinical information for predicting the outcomes of our patients is obtained.
Yeah, there's some challenges still into identifying those low-risk people, and we've had some situations come up recently where we think somebody's low risk, and low risk doesn't mean no risk. So I think maybe some of those answers will come to us through imaging, some through genetics, and some through some good old-fashioned hard work and data analysis. So we're hoping for that. What areas still are the holy grail? Where do you think we could be going if you were to be able to dream a little bit?
Well, I think the population of individuals genotype positive to carry the pathogenic gene that their family member, parent may have had, and they don't have the disease. How we can prevent the emergence of disease in those individuals where we can keep that gene sleeping rather than get active and produce the condition. And that, to me, is one of the very exciting areas right now for research. And a lot of work for many centers is going on. I'm fully aware of that. But there has to be some way that we can get this group protected from the disease in the future. And also, of course, in the area of trying not to get the disease transmitted by the young couple. So to advise them about in vitro, fertilization methodologies to avoid passing the gene, and the newer CRISPR technology like coming, which may have a very important role down the road, not at present, but down the road. So
I
those
just
are
really
things to prevent and stop the disease from propagating further. But right now we are dealing with the established disease individuals and trying to manage them the best so they can have a very productive life and complete life.
I would agree completely with both of those. They're great areas to look at. We just had a fantastic story of a teenage young man who was diagnosed with HCM, had one of the early ICDs in a teen. He's no longer a teen. He's married and just became a father to an HCM-free baby. And we're really excited for him. And I just then heard a nice talk at AHA about CRISPR technology. Actually, Beth McNally gave a really good plenary session talk on the hopes for CRISPR and what we're seeing, but we're probably still a bunch of years away from practical application in the masses, but it is coming. So I'm really excited about that, because wouldn't it be lovely if we could just make it go away? It sounds simple, but it's not necessarily so. So we have some comments here I wanted to post, and let's see if we can, I'm having a hard time with technology here. Let me just click that little button. There we go. So we have one of, where are we going? There's Liz. And I don't know if Dr. Tajik can see that. This is Liz, that she saw you last year, and she thinks she's in really good hands. So hi, Liz. And then we have another message here from Paula.
Hello, Liz.
So I told you might know some of these names that pop up, and you never know who they're going to be. So that's another nice, nice little promotion there, and people are happy with the care. I can't imagine why they wouldn't be. I've been there and seen the center myself, and was really excited to see such an engaged partnership with the entire team. So let's pull Paula down there. Oops, where did it go? There it goes. All righty. So we don't have any questions coming in right now, so I'll take a moment and I will prime the pump on asking some of the common questions. And this one comes up every once in a while, and it recently came up in a conversation I had with somebody. Emergency room visits for HCM are complicated because many ER docs don't really appreciate us. Should somebody with HCM show up in the emergency room and the troponin levels are just a little bit high, not like they're having a heart attack high, but slightly elevated, can you speak to what that might be caused by, and should patients be very concerned that they have mildly elevated troponin levels?
So very good question. And so the way we handle this, because troponin is checked routinely on every patient with hypertrophic cardiomyopathy in our center. The troponin leakers, we sit down and have a very good, more detailed discussion with them, what it implies. Microscopic death of a cardiac cell taking place, okay?
Right.
We also instruct them that when they are by any chance in an ER, they need to inform everybody that they are a troponin leaker. Otherwise, they create a whole big saga for the team in the ER, because in ER they have to make very rapid decisions. And these young people show up, and unfortunately those who have not related that information to the ER caregivers, they are sent directly to the cath lab for coronary angiogram because they're leaking troponin, they have some kind of chest pain that took them to the ER, and that scenario gets repeated. So we inform them to inform their caregivers wherever they are that they are troponin leakers, and they should not excite them too much unless the numbers have gone very high. And of course, then we got to look into that.
So it would be well advised for patients with HCM to make sure that they've had their troponin levels checked,
Yes.
maybe repeatedly checked with their cardiologist, and to know whether or not they tend to leak a little bit of troponin or not.
Right. That, at least that is the standard practice we follow. I've instituted that for many years.
Fantastic. Melanie has a question for you. Are septal myotomy, myectomy, and myectomy the same procedure?
Yes, myomectomy and myectomy are the same procedures, different names. And the other one is simple myotomy, used to be another term used here, but they are all designed to reduce the thickness of the basal septum where the obstruction takes place in vast majority of cases. And in some, then it is at the apex where apical myectomy is performed.
And some other names that they may hear is the Morrow procedure, which is dating it quite extensively and named after Dr. Morrow, who was both a surgeon who developed the procedure and a patient with hypertrophic cardiomyopathy, as fate turned out to be.
Himself, yes.
Very interesting story for a whole other conversation on some other point.
So basically what most surgeons are now doing is what's called the extended Morrow procedure, in a way, and each innovative surgeon adds their own twist to it to get the best results.
So she asks an additional question that her surgeon calls it a myotomy or myomectomy, and it's involving her mitral valve as well. So let's talk for just a moment about mitral valve involvement in HCM. What do you think?
Yes, so there are a number of mitral valve abnormalities intrinsic in the patients with hypertrophic cardiomyopathy, just from being elongated leaflets to abnormal attachments of the caudal apparatus and papillary muscles in this particular hypertrophic disease. But simply in patients who have left ventricular outflow tract obstruction from bulging of the ventricular septum, thick septum, bulging like a knuckle into the flow of blood coming out of the left ventricle, the mitral valve plays a very critical role in causing that obstruction, and that's referred to as SAM, or systolic anterior motion of the mitral apparatus, leaflets. And then secondary mitral regurgitation or leakage of the blood from the mitral valve into left atrium almost uniformly occurs in such individuals with severe outflow obstruction. And the beauty of that is that vast majority of those mitral regurgitations resolve after doing a good myectomy of the LV outflow tract, the muscle reduction. And that also cures, in a way, the mitral regurgitation in vast majority of such cases, unless they have additional intrinsic abnormalities of mitral valve or the mitral apparatus. Then a surgeon has to address that at the same time as myectomy is being performed.
So would you think that if you did a proper assessment of a patient going into myectomy, that we can predict pretty much who's going to need either a significant mitral valve repair or, in the rare cases, a replacement?
That can be very reliably predicted and assessed preoperatively by echo and selected cases, TEE and MRI.
Yet again, why the team approach is critical to choosing the right patient for the right procedure at the right time, and really aligning
and at the right place.
And at the right place, of course, at the right place. But the expectations, we don't want a patient going into surgery thinking it's just a myectomy and then being disappointed when they come out and find out why, they had to have their mitral valve repaired or replaced. You should know it before you go in. In almost all cases, it's not a guarantee, though.
Yeah.
Okay. So Melinda, thanks you very much for your comments, because it's giving her some peace of mind. So we don't have any other questions pending right now. We'll give them another second or two to write them if they have them. But I just want to say how absolutely thrilled I am to have the knowledge and the skill and the experience of Dr. Tajik and his team really finally merging officially with the HCMA so that we can help provide patients in that region access to the highest quality care possible and help to grow the program so that more patients in the region will have access to high quality HCM care. So I thank you very much, and I thank your team. I
am so thankful that we are part of this fantastic organization that you have developed. I'm very impressed what you have really spearheaded, and with all the energy you have devoted to this condition, to advance knowledge, help patients. Well done, Lisa. Well done.
Thank you, Dr. Tajik. And thank you to the rest of the team at Advocate Aurora St. Luke's. They've got a very long name. I got to get it all in there. And thank you for spending some time today to everybody on Facebook. And please share this and make sure everybody knows that we have another HCMA recognized Center of Excellence right here in Wisconsin. And a programming note, we were supposed to go live tonight with Dr. Matt Martinez, the new addition to the Morristown Medical Program. However, that's going to be later in December due to some scheduling issues. So sorry about that for those looking forward to it tonight. It'll be in about 3 weeks in December. So thank you all and have a wonderful day.
Thank you. Thank you. Have a good day. Okay. Bye.
And